Hey, good evening, one and all. Looking forward to this session tonight on dyslipidemia and hypertension. And we'll wait 3 more minutes till we get to the top of the hour so that we allow everyone who has signed up to attend. So if you would like, how about let's giving it a try with this. Toss in the chat where you're dialing in from. I'm in Massachusetts, in beautiful Cape Cod, Falmouth, Mass. And whenever I talk about Cape Cod, this is what Cape Cod looks like. We're about right there. We're about right there on Cape Cod. And where it actually got into the mid 80s today, which is really unusual. We've got Iowa City, Austin, Texas, Wakefield, Mass. Hey, Jen Callahan. Hi. I'm a Wakefield High graduate. Um, let's see. Maui, how wonderful. We're going to be in Oahu in January. Central Florida, Omaha, Baton Rouge, couple of people from Baton Rouge, Central Illinois, West Lafayette, Indiana, Homestead, Florida, Collegedale, Tennessee, Clifton, New York, West Virginia, New Jersey, Agawam, Mass, which is Western Mass. Massachusetts isn't very big. We can get from one end to another in no time. We've got California, Ohio. You know what? I think we need haven't seen it, but I've got the feeling that we have every single time zone in the United States represented, short of Puerto Rico, which is in a different time zone than the US mainland. So thrilled. North Carolina, Dallas, we've got people, Michigan. So we've got people who I'm sure it is very hot outside, and some places where it's, as I whine about it being 85 degrees on Cape Cod today, I bet a lot of you are under much, much warmer circumstances than that. So anyway, thank you. Thank you. Thrilled to see the turnout for this, particularly now that we're well into summer. So 1 more minute and we'll get going. And what I would also like to ask of you, and I'll reiterate this when I'm through the program, is questions to me put in the Q&A box, which you can access by going to where there are the 3 little dots, hitting there, and then Q&A will open up. And questions to Riley, who is on to help us tonight with any technical issues or support that can go into her into the chat box for her. Okay, welcome to the program on hypertension and dyslipidemia, focus on best evidence. And of course, this is a series that I've put together to help faculty with teaching pharmacology, which is one of the backbone subjects of an NP program, but it is often one of the most vexing of the people who are graduating from our NP programs and entering into their practice. So a little bit about my background. I am I'm Dr. Margaret Fitzgerald. I'm the founder of Fitzgerald Health Education Associates. My clinical practice has been in a federally qualified health center for more than 35 years, where I take care of everything that comes through the door: pregnancy, the little ones, the people in the middle, the old people, and true family practice, where I've had up to a 5-generation family in my practice. It's been a great privilege to do this work. I'm also on faculty at Case Western Reserve University, which is where I did my doctoral studies. I sit on the editorial board of a number of different publications in the NP world, and I'm a member of the Pharmacy and Therapeutics Committee for Mass General Brigham Health Plan, which is a major HMO in largely Southern New England. And just as an aside, whenever I'm teaching NP students, I always put this slide up. And one of the reasons I do this, because as they're struggling with getting through their NP programs, I teach literally thousands of people per year how to get ready for their NP boards, and they're at that, whose big idea was this part of their professional development? We've all been there, right? As we were getting ready to graduate, going, what the actual heck have I done here? Yeah, because it's such an enormous role transition. I always go over that, and then I throw in I'm an author, an entrepreneur, a few other things. I'm a lasagna love volunteer. I've got 2 lasagnas being picked up tomorrow, going to a sober house. I do a million other things, million other things. But one of the reasons why I bother and take the time to go over that, I want them to see what they can do as a nurse practitioner. So that's the main reason why I do that. And I always say that to them is this gives you an idea of what you can do as an NP. Okay, disclosures, no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented. If I do talk about anything off-label, it will be identified as such. So what are we going to do here? Upon completing the learning activities, the participant will be able to identify the appropriate use of hypertensive meds to reach high blood pressure goals, identify special considerations in hypertensive therapy, describe key components and global goals of dyslipidemia therapy, and recognize those teachable moments and student pain points and the treatment of hypertension and dyslipidemia. References will be throughout the presentation. So what's our goal as educators? And what are the students' goals? Have you ever noticed there can be a little disconnect between what our goal is and what the students' goals is? And of course, we also have the goals of the preceptors. What are the expectations of the preceptors? Unfortunately, we are a profession that largely educates our young on the backs of volunteers. And we've all volunteered. I know I have countless people who I've precepted, but it is an interesting system. And what are the students' goals? Are the students' goals primarily success on the NP boards, preceptors' expectations that they are literally exam room ready? And we have both of those, do we not? Do we not? And remember, how were the NP boards developed? And this is a quote from AANP. The exam, this is from AANP. The examination blueprints are based on practice analysis, are an objective measure of the knowledge and skills required by a competent NP. And I have really been reinforcing that with people over the last few years, is to remind them that the boards were developed on an analysis of practicing NPs and what they do. And those practicing NPs for the family and the adult gero primary care folks were just that. They were NPs practicing in primary care, either prepared as family or adult gero folks. So that's important for them to keep in mind, because what they're going to be tested on in the boards are their clinical decision-making skills. And that's what it all boils down to. Do you have enough knowledge? Can you apply that knowledge to be a safe clinical decision maker? Okay, so what about pathophysiology? I like using this model when I'm talking with people, NP students, people getting ready for the boards, is the application of pathophysiology, because of course they read through the handbook or whatever's online about what's going to be in their boards. And one of the things that we'll say is there could be questions on pathophysiology. And I like to reinforce that it's more the practical application of pathophysiology. You're not going to be asked what is going on at the level of the mitochondria during cardiac ischemia. No. We should know that, but it's not going to be that much. But what's the pathophysiology of high blood pressure? Well, remember, blood pressure equals heart rate times stroke volume times peripheral vascular resistance, or the resistance in the arterial bed. And implied in this formula, if you increase any or all parts of the formula, blood pressure goes up. Decrease any or all parts of the formula, blood pressure goes down. Where does most hypertension come from? It comes from a rise in peripheral vascular resistance. Now, some of this is age-related. The pipes get stiffer as we get older, okay? But interestingly, heart rate times stroke volume, i.e. cardiac output, tends to go down as we get older. And that is one reason why new onset hypertension in older adults is more commonly systolic hypertension. So systolic number up, but diastolic number within a normal parameter. Where high blood pressure in younger folks, it's usually systolic and diastolic. Both of those are up. So what do we have for guidelines? And I will tell you, sometimes I have to kind of smile a little bit here because, questions from customers, from people who getting ready for the boards will often come to me via customer service, because with my company, we have a way of people asking questions. And we actually have a canned response for this one. Which set of guidelines for hypertension will be on the NP boards? And the answer is yes. Actually, they're practically the same set of guidelines. So what would be reflective on boards is what would cover the recommendations of either set of guidelines. So why is it JNC 8 and AHA ACC blood pressure clinical practice guidelines emphasize the use of ACE inhibitors or ARBs, thiazide diuretics, and calcium channel blockers, those first-line drugs, due to comparable clinical outcomes with cardiovascular, cerebrovascular, and renal outcomes? It's as simple and as complicated as that. So just a reminder of where you can get your hands on these different guidelines, which I'm sure you're all aware. So what are some of the therapeutic principles in treating hypertension and dyslipidemia? It needs to be stepwise approach, evidence-based, and goal-directed. And by the way, anything that I have here, I've got some case studies. Feel free to use them with your students as long as you give attribution. That's all I ask. So to get back to the issue of which set of guidelines on the boards, when well-recognized clinical recommendations have differences, concentrate on the overlap, because that's what bogs people down. JNC 8 has less, shall we say, less stringent goal blood pressure recommendations of less than 140 over less than 190, compared to AHA ACC, where they say less than 130 over less than 80. I think clinically, most of us are going with the less than 130 over less than 80. I also look at some of my patients and say, well, that's aspirational. We'll get there sooner or later, but it's going to take a lot of lifestyle modification, a lot of tweaking medications to get them down to that part. So one of the issues that I note that the new NPs struggle with is most of them are in the acute care setting, correct? They are. And what do they notice? Somebody's blood pressure is sky high in hospital, and they get an IV med, and the guidelines do say, like, let's say somebody presents truly with hypertensive emergency. Generally, BP is greater than 180 over greater than 110 or 120. I'm doing this off the top of my head, which is always dangerous, but more likely like 220 over 120, and is having some signs and symptoms of target organ damage or target organ dysfunction from their hypertensive crisis. And what do we know? IV meds within 6 hours. The recommendations are you can bring the blood pressure down to about 160 over 100. So they saw this person who was 220 over 120. 6 hours later, they're 160 over 100. And the the recommendations do say let them sit at that level for a little while with a goal of bringing their blood pressure down to a more normal level within about 24 hours. So what I find is the NP students expect somebody is going to start on a high blood pressure on Monday, and by Tuesday, we're going to notice a big drop in their blood pressure. It don't work like that with the PO meds. It doesn't. So I'm going to give you some information to share with your students on how much you can actually expect out of a given blood pressure med. Not a lot of times do people talk about that. But anyway, high blood pressure, it's a complex disease with a core defect of vascular dysfunction that leads to this select target organ damage, minimizing and treating high blood pressure to the EBP advised BP goals minimizes the risk of that hypertensive TOD. We all know what these are, but I wanted to put them in one place: the brain with stroke, multi-infarct, or vascular dementia. Cardiovascular system. Yeah, yesterday's news. We know about myocardial infarction and atherosclerosis, but remember, the biggest risk for the development of LVH is poor, long-standing, poorly controlled hypertension. And in fact, that the development of LVH is a potent antecedent event to the development of heart failure. And people with LVH have a higher risk of sudden cardiac death. We want to desperately, desperately avoid the development of LVH. By the way, LVH is reversible with a sustained period of time of blood pressure control. The kidney with hypertensive nephropathy, people with receiving dialysis, almost all of them have hypertension. Almost all of them do. The development of CKD. Now, one thing that we do all tend to do is look really, really carefully at GFR, right? We do that, okay? And serum creatinine. But please remember, persistent proteinuria is the warning. That is the scream of the sick nephron that is saying, yeah, I can push myself and still have a decent GFR, but this poorly controlled high blood pressure is damaging me so badly, I'm letting protein slip through. I was actually surprised with the last iteration of the blood pressure guidelines that there wasn't more of an emphasis on looking at proteinuria, persistent proteinuria, as something that we need to be really aggressive about, just like we would with diabetes. And then, of course, hypertensive retinopathy with the risk of blindness. So remember, all of the first line high blood pressure meds work by lowering PVR. That's how all of them work. And the class of drugs that doesn't work on lowering PVR is a secondary, the second line, if you will, meds for outpatient therapy, which are the beta blockers, and they work by lowering heart rate and stroke volume. Okay. So we all know what the guidelines say. All right. And the guidelines say, okay, thiazide diuretics, calcium channel blocker, ACE inhibitor, ARB. This is JNC8. Black, we want to prioritize thiazide diuretics or calcium channel blockers. Again, I'm quoting what they're saying. Okay. Non-black, I just have to go on record and saying, it bothers me when anyone or group of people is described as being a non-something. But again, this is their terminology. Non-black, thiazide diuretic, calcium channel blocker, ACE inhibitor, or ARB. With CKD, you include an ACE inhibitor or an ARB. Now, it's interesting, neither JNC8 nor ACC-AHA throw in the comment about prioritizing ACE inhibitor or ARB in diabetes, but of course ADA does. All right, ACC-AHA, same deal, same deal. They really have almost the exact same terminology. However, do we want to encourage our students to say, okay, Well, look at somebody's skin tone. Decide who's Black and not. I practice in a predominantly Latino community. Just let me know on that one. Where most of my patients do have African ancestry. At the same time, they would not self-identify. The majority would not self-identify as being Black. They would not. So what do we want to do here? And this is, I gave you the citation on this one. The time has come to shift the focus from race-specific monotherapy monotreatment recommendations by adopting a comprehensive team-based multi-level care models that use race-informed communication, self-care, dietary strategies, coupled with race-agnostic treatment algorithms that minimize therapeutic inertia and promote prescription of adequate intensity of drug therapy. Amen. And you know what? I can proudly say that after 35 plus years within one of the lowest income urban neighborhoods in a 6-state region, all of New England, I've never had a patient go on dialysis, and I've treated literally thousands of people over the year with hypertension, type 2 diabetes, and dyslipidemia. I'm knocking wood while I say that. Okay, I've got a couple of people in their 90s who GFRs aren't that great anymore, but they're in their 90s. So, and to a certain degree, they did wear their kidneys out. But one of the things is, and I've had people say to me, how did that happen? I was like, because I didn't care what color their skin was. I made sure a maxed out ACE inhibitor or ARB was part of their therapeutic regimen. And unfortunately, there have been historically, maybe not so much now, a thought that, quote, ACE inhibitors and ARBs do not work in people of African ancestry, and it's absolute foolishness. All right, so when we look at these and what are mechanism of action, often of the commonly prescribed high blood pressure meds. And remember, mechanism of action often dictates adverse effects and monitoring recommendations. So the thiazide diuretics, hydrochlorothiazide and chlorthalidone. Interestingly enough, chlorthalidone is the thiazide diuretic that's used more worldwide than hydrochlorothiazide. We kind of stand alone as almost the only country in the world that uses hydrochlorothiazide more than chlorthalidone. Chlorthalidone is more potent, hands down. Sometimes a switch from hydrochlorothiazide to chlorthalidone is all you need in order to bring blood pressure down a goal for a person who is approaching but is not at goal. Mechanism of action, it reduces sodium reabsorption, adverse effects, hyponatremia, hypokalemia. All right, how do you avoid the hypokalemia that can go along with thiazide diuretics? Always, 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 always use them with an ACE inhibitor or an ARB. Okay, ACE inhibitors, suffix for the class are prils, ARB are sartans. I find people love having that pointed out to them. It seems like a lot of people got taught pharmacology without looking at drug suffixes or prefixes to figure out what class they're in. Mechanism of action, RAS blockade, so renin, angiotensin, aldosterone system blockade via different mechanisms. Adverse effects, this often does come up as a board question, the high blood pressure medicine that can make people cough, and it's ACE inhibitor. And the cough can be as much as little as 5% of people put on it or as much as 35%. General rule, the number that's tossed around the most is 8%. And that ACE inhibitor-induced cough can literally come on after somebody's been on one of these meds for years. One of the longest stretches, I had a patient who was on the ACE inhibitor for 15 years before she developed the cough. And I had another patient who started like her ACE inhibitor on a Monday, was coughing by Thursday. Okay, so I mean, you know, it really is quite variable. And then with both, in angioedema, ACE inhibitor induced angioedema, the biggest risk for that is NSAID allergy. If somebody develops angioedema while on an NSAID, there's a high likelihood they're going to do it on an ACE inhibitor because it's similar mechanism. And with both hyperkalemia, especially with CKD and underhydration. So one more time, if you want to ameliorate the hypokalemia from the thiazide diuretic use, always, always, always use it with an ACE inhibitor or an ARB. Calcium channel blockers. These work directly on PVR reduction, and that's their mechanism of action. This is the most potent and most rapidly acting class of antihypertensive meds, far and away, hands down. And because they're so good at dilating arteries, they also dilate veins while they're at it. And that's where the ankle edema comes from, particularly in higher doses. And if you're going like, well, how high is high? Hold that thought. I'm going to go over that a little bit more later in the program. There are two subclasses, the dihydropyridines, like amlodipine, aka Norvasc. Norvasc is the most commonly prescribed calcium channel blocker in this country, and the non-dihydropyridines like diltiazem, and that is far less commonly used. So here is a question that often comes up. Are you better off maxing out a dose of a given high blood pressure med or adding a second med class? And I've got a question in the NP boards about a patient who comes in, I think he's on a calcium channel blocker, and his blood pressure is down from his last visit, but it's still not at goal. And the question I always get asked from the students is, yeah, but they didn't tell us what the dose of the calcium channel blocker was. No, they didn't. They didn't. So you have to work with the information that you've been given. And the correct answer on that one is actually to add a second med. And here is the rationale for that. So which approach is better in treating high blood pressure? Monotherapy, start with one drug class, increase the dose, add a second drug if moderate to maximum effect with the first drug not sufficient, or early combined therapy, preferably two meds and start two drugs at the same time, preferably in one tablet, and titrate the dose, and then add additional meds as needed. So who should the monotherapy be considered in? Like starting with a single drug. Best suited for older adults, 80 plus. And I gave you the citation on that a couple of slides ago, because great, very, very common sense article. And I know I'm committing the sin of giving you an article that's more than 5 years old. It's from 2019, but not a lot has changed in high blood pressure since that was published. So why would we want to do that? Increase risk for adverse effect with hypertensive therapy, and need to focus on function and safety, particularly if they're frail. I'm going to throw in another little nugget there of who I always start on monotherapy. The person who has come in and said to me, I have known I've had I'm 50 years old. I work in a warehouse. I drive a forklift truck. I climb a ladder 3 or 4 times a day, if not more than that. I'm not on any high blood pressure medicines right now because I've never felt good on them. Oh, tell me what you mean by I don't feel good on them. I always feel lightheaded. Anybody see a safety issue with that? Yeah. So what I'm going to do with that person is, yeah, that person's only 50 and the BP is 195 over 105, but I'm going to creep that blood pressure down over maybe 6 months and let them adjust to having their blood pressure lower, as long as they do not have evidence of accelerated hypertensive TOD, which they generally don't. So who is early combined therapy best for? People whose blood pressure is 20 millimeters of mercury or more, or 10 millimeters of mercury or more above goal. I don't think I've ever seen anybody whose blood pressure wasn't higher than that, particularly if they've got significant ASCVD risk. There's evidence of enhanced adherence, particularly with a single drug combined therapy. All right, so this is, remember I was saying this before, I'm going to give you an idea of how much it brings down, the different meds bring down the blood pressure. So ACE inhibitor, ARB, anticipate a 7, for systolic blood pressure, an 8 to 10 millimeter drop, diastolic, a 4 to 6 millimeter drop. Thiazide diuretics will be about a 7 to 12 millimeter of mercury drop, systolic, diastolic 4 to 6. And dihydropyridine calcium channel blocker like amlodipine, 8 to 12 millimeters of mercury, systolic in 4 to 8 millimeters, diastolic, non-dihydropyridine calcium channel blocker like diltiazem, systolic BP drop of 5 to 10 millimeters of mercury, diastolic 5 to 8 millimeters of mercury. So that's how much you can get out of each med. Now, here's the other thing. What are the recommendations for both sets of guidelines? How long do you give that med to work? 1 month. 1 month. That's when you will appreciate the full clinical effect of the blood pressure med. So true or false? And a meta-analysis of clinical studies indicated that low dose, 12.5 to 25 milligrams of chlorthalidone or hydrochlorothiazide, and high dose, 50 milligrams a day or most or more of both drugs, diuretic therapy, lower BP to a similar degree and exert similar effect in reducing stroke, heart failure, cardiovascular, and disease and total mortality, but only low dose therapy significantly reduced CHD incidence. True or false? And that's actually true. And you know why? Higher dose thiazide therapy, thiazide diuretic therapy, worsens insulin resistance. And you're stuck with all those metabolic parameters that likely are the contributing fact. And so true or false, data obtained with chlorthalidone so far indicates the plateau of dose-dependent antihypertensive curve is reached with a daily dose of 25 milligrams, and then increasing the dose does not increase the blood pressure lowering effect, but further increases the occurrence of negative metabolic effects, particularly hypokalemia. In other words, yeah, your drug app says you can go up to 50 milligrams of chlorthalidone a day, but don't do it because you're not going to get any more blood pressure control. And that's also true. And remember, the metabolic effects include worsening insulin resistance, increasing LDL, and triglycerides. There is a general rule with high blood pressure therapy that when you are to 50% of the dosing interval, so the dosing interval being the smallest to the largest dose, when you're at the 50% mark, you've gotten about 80 to 90% of the blood pressure lowering effect out of that. So going to the full dose, you might get 1 or 2 more millimeters of mercury blood pressure drop out of that. You're better off with the second med. So which 2 drug therapies in no particular order, but in the absence of comorbidity, an ACE inhibitor and ARB with a long-acting diuretic. Chlorthalidone does have a longer half-life when compared to hydrochlorothiazide. There's evidence of synergistic effect of the ACE inhibitors and the ARBs together with a thiazide diuretic, so it brings down blood pressure even more than just adding the 2 numbers I gave you before. A long-acting calcium channel blocker with a long-acting diuretic. The third drug, if they need to go to a third drug, which the majority of people will need to be, whatever they've not been started on yet. Okay. And how much blood pressure lowering will you get with these combinations? ACE inhibitor, ARB with thiazide diuretic. You could see you can get up to 25 millimeter systolic BP drop, 15 to 25 millimeters, diastolic 8 to 15, and RAS inhibition enhances the effect of the thiazide diuretic and spares potassium. So here's a good example to show to your students. Patient shows up with a BP of 190 over 100. We give them an ACE inhibitor or an ARB with a thiazide diuretic. Best case, they're come down 165 over 85, and it's going to take them a full month to get to that number. It is. It is. So what we have to do is one of the things that I always think of when I'm dealing with students and they're going like, oh my God, his blood pressure is 190 over 100 and he's going back to work. I was like, yeah, and how long has it been 190 over 100? He's 50 years old. Last time he had his blood pressure checked, he was 30. He's probably had high blood pressure like that for 15 years. 10 anyway. We don't have to fix him today. And as long as he's safe with no signs and symptoms of accelerated hypertension, yeah, we're going to start him on something today and see him back in a month. And that's all we're going to do. We're not going to try to lower his blood pressure more. Okay. So, and if you add a dihydropyridine calcium channel blocker to the ACE inhibitor or ARB with thiazide diuretic, you're going to get another 5 to 10 millimeters of mercury blood pressure drop systolic and 2 to 5 millimeters of mercury drop diastolic. Now, you'll note it's not as much as when we were talking about CCBs as monotherapy. And so, and the reason for that is the blood pressure has already been dropped so much. So general rule, first BP med, regardless of class, affords the most BP lowering. And then when you add the second, third, and fourth meds, less BP lowering. So just remember what all of these different drugs do, okay? So one more time, we're back to that case example of the person went from 190 over 100 with an ACE inhibitor, ARB, or thiazide, with a thiazide down to 165 over 85. We add the calcium channel blocker, we're down to 155 over 80. Now that beats the heck out of 190 over 100, doesn't it? Okay. But are you at goal? No, you're not. No, you're not. All right. And with some other combo therapies with diabetes and CKD, it just suffice to say, we always want to have an ACE inhibitor or an ARB on board. And that one of the things is with the dihydropyridine calcium channel blocker, remember, and this is critical, having a maxed out, and I can't say this strongly enough, maxed out dose of an ACE inhibitor or ARB will mitigate the peripheral edema that comes with a calcium channel blocker. Okay, never, ever, ever boost the thiazide diuretic dose to try to get rid of that ankle edema. It is a mechanical ankle edema from the vasodilation. What I will always say to students is it's a little akin to ankle swelling in late pregnancy with that venous vasodilation. Gives women who don't have heart failure, who don't have preeclampsia, they have nothing else going on, but their ankles are swollen because they're pregnant and their venous vasodilated. So it's similar to that. It also has an anti-inflammatory effect. But I've heard or seen that using calcium channel blockers can cause ankle edema. Absolutely. What is the rate, though? If you stick down around 2.5 milligrams, the lowest dose, it's 2 to 5%. Go to 5 milligrams, it's going to be 5 to 10%. Go to 10 milligrams, it's as high as 30%. So in my world of prescribing, I never go above 5 milligrams of amlodipine. I just don't. You don't get that much more blood pressure control, and you get the proverbial cankles, and people are not amused. And another thing is, remember, is it fluid retention or peripheral arteriolar dilation? It's more the peripheral arteriolar dilation. All right, this is a great case study. Great, I developed it. So let me get off my high horse here. Okay, but it's helpful for the students. A 55-year-old male who's a warehouse supervisor with high blood pressure. He's at therapeutic goal. He's on amlodipine 10 milligrams and hydrochlorothiazide 25 milligrams daily, states he's generally feeling well, no dyspnea or chest pain, but has mild ankle swelling, most notable at the end of the workday. Health history and physical exam are unremarkable except for mild bilateral ankle edema. Which of the following recommendation is recommended to mitigate the ankle edema? Choose two that apply. A, add a loop diuretic. All the ER people want to do that when I pose this question to a group. That's not the correct answer. B, reduce the amlodipine dose. C, add an ACE inhibitor or an ARB. D, add an aldosterone antagonist. And the correct answers are amlodipine, B, and C. Now, the other thing I have to throw in there is support hose. Elevating his legs whenever possible is also good, but B and C are the best answers. So when should you see the patient back? As I mentioned before, AHA-ACC says 1 month after med initiation or dose adjustment. You know what? You always use your clinical judgment on that one. And if I've got a patient who has not, if I have a patient I'm really worried about, like worried they wouldn't have, concerned they wouldn't have started their meds. I've got labs I want to go over with them when they come back, next time they come back. I'll see them in 1 to 2 weeks just to make sure they're on their meds. I can go over the labs with them, but I'm not expecting a big miracle from their blood pressure at that point. And this goes beyond the scope of this presentation, obviously, but the whole issue of monitoring blood pressure at home, key. And I always say that to patients, give the meds a full month. And then if they've noticed their blood pressure has dropped in 1 to 2 weeks, they're thrilled, you know. And so it's always good to make patients feel like they're doing well, isn't it? All right. So should I send this patient to the ED? A 54-year-old woman presents with the chief complaint of frontal headache for the past 2 days. And she says, I think this might be my blood pressure. I take 3 meds and ran out about 2 weeks ago. BP 178 over 102 bilaterally. Denies chest pain, visual changes, dizziness, back pain, shortness of breath. Admits to history of similar headaches. Partial relief of this headache with acetaminophen, and in general forgets to take her blood pressure medicine about 1 time a week, but now admits she's not been on it for a while. Her meds her prior meds for the treatment of blood pressure included the following: captopril, TID, propranolol, BID, hydrochlorothiazide daily. She also reports taking ibuprofen several times a week due to knee pain. She has some arthritis in her knees. She's alert, oriented, grade 1 hypertensive retinopathy, cardiac exam within normal limits with the exception of an extra heart sound. Neuro exam normal, abdominal exam is normal. So what is that abnormal heart sound? Is it likely an S3, the sound of systolic dysfunction, or S4, the sound of diastolic dysfunction? And it is the S4 heart sound. And that's the sound of the stiff left ventricle because her blood pressure hasn't been in control for a while. So cardiac assessment tip, the S4 is heard just before the S1, late diastole, higher pitch. S3 is right after the S2, early diastole, lower pitch. And a little assessment tip to share: they can't figure out which is the S1 and which is the S2. Lightly press the fingers on the carotid while auscultating the heart. The heart sound heard nearly simultaneously with the upstroke of the carotid is the S1 heart sound, okay? Somebody like this, good likelihood they'd have LVH on the electrocardiogram, unusually deep S waves, unusually tall R waves. Big left ventricle makes big waves on the 12 lead. So true or false, the presence of LVH in hypertension is an independent predictor of adverse cardiovascular outcomes, including heart failure, dysrhythmias, and sudden cardiac death. Kind of gave that away earlier, didn't I? And that's true. An established LVH is unable to be reversed. And that is, of course, false LVH regression equals better cardiovascular outcomes. And how do you regress LVH? It's a muscle that has overworked, so you make it work less. And sustained, consistent lowering of blood pressure can take months, perhaps years. I had one guy in my practice with decades of poorly controlled high blood pressure. 1.5 years later, he had a left ventricle the size of West Texas. It was gigantic. And it went down to pretty much the high end of normal after 1.5 years of really good blood pressure control. How many meds are needed? Likely 3 to 4 drug therapies. This guy was on a calcium channel blocker, thiazide diuretic, maxed out ACE inhibitor, ARB, I don't remember which one, and a beta blocker. He needed 4 meds to lower his blood pressure. And a person who presents with markedly elevated blood pressure but feeling well, which is acceptable in hypertensive urgency. Remember, hypertensive urgency, you don't send people to the hospital for that. Choose all that apply. Could it be a S4 heart sound? Yes, because that's consistent with long-standing high blood pressure. Grade 3 hypertensive retinopathy? That's high grade. That means there's bleeding behind the eye, even if the person says, I feel okay, except for these black spots in front of my eyes. Bye-bye. You're leaving my primary care office. You're going to the ER. LVH on ECG? Yes, that's a non-acute change. So that's okay in hypertensive urgency. Neck vein distension? No, because likely in heart failure, needs to get out of the office. So what about elevated blood pressure with a non-specific complaint like a nosebleed, but no evidence of accelerated target organ damage? Do a 30-minute rest, see if blood pressure lowers, treats the non-hypertensive complaint to see if it improves under observation. And so with this woman, a gram of acetaminophen. She rested in a quiet room for quiet exam room for 30 minutes. I did get kind of the stink eye from my my MA from tying up an exam room for a while. But I just said to the MA, go in and check on her while I'm seeing the next patient. Make sure she's got some water to drink. Keep the room cold, cool and quiet. How about put a cool cloth over her forehead? The MA did all of those things. Half hour later, her blood pressure was came down to 160/100, and she had resolution of her headache. So we were able to demonstrate under observation that her headache would go away with that therapy. So what about her meds? Captopril TID. Oh, for the love of God, give her a once-a-day med, please. Who is ever going to take a 3 times a day med for everybody, for every day of their lives? Propranolol? No. No. She had no reason to be on propranolol, and it was BID to boot, and hydrochlorothiazide. She also says she uses ibuprofen several times a week for her knee pain. I've been told not to take ibuprofen because she's got high blood pressure, but it's the only thing that helps. And so where to start, what to switch out. This is a great farm exercise to do with folks. Get rid of the captopril, switch over to lisinopril, okay? And you can do this as a hot switch. Monday, she took her captopril. Tuesday, she can just go on once-a-day lisinopril. Don't restart the beta blocker unless there's a compelling reason. There was no particular compelling reason. And you might say, yeah, but what about headache prophylaxis? Her headaches were actually not that frequent. She usually had like 1 headache a month. Consider chlorthalidone instead of hydrochlorothiazide because her blood pressure is super, super, super high. And consider adding a calcium channel blocker given the NSAID use, because every other med on this slide will have its clinical effect minimized by the use of an NSAID except a calcium channel blocker. All right. So let's wrap up and talk about dyslipidemia. And the thing is, dyslipidemia treating it is so important. But as I say when I'm teaching NP review is, and I hate saying this, I said, statin will almost always be the answer on the boards. But we don't want people just thinking about the boards. So I suspect you're all aware of this cardiovascular risk calculator from the ACC AHA guidelines. And the purpose is to estimate the patient's 10-year ASCVD risk at an initial visit to establish a reference point and clinician-patient discussions on risk and risk-lowering interventions. And by the way, I know I'm talking meds. This is a pharmacology presentation. I in no way, shape, or form want to minimize the critical importance of lifestyle modification, but I know you're talking to your students about this. So what I was trying to do was really focus in on pharmacology. Excuse me. And the same thing applies for dyslipidemia. For patients with diabetes, people with diabetes, age 40 to 75, with higher cardiovascular risk, high intensity statin therapy that lowers the LDL by 50% or more of baseline, and you want to get them to a target LDL of 70 or less. Okay. So when you look at this table, and this is an extraction of the AHA ACC guidelines. It is something that I've put together to kind of just boil this down. Feel free to share with your students. And so the evidence clearly supports statin therapy if the 10-year ASCVD risk is 20% or greater, ages 40 to 75 with diabetes, or if the LDL is greater than 190 when they present. By the way, anybody whose LDL is greater than 190 at presentation probably does have familial hyperlipidemia. And those are the folks that, God bless them, if they, ate celery and drank water, they're still going to just have a sky-high cholesterols. So high-intensity statin therapy, it's only atorvastatin and rosuvastatin. You can't squeeze it out of the other statins. Why is that? It's all about pharmacokinetics. Atorvastatin and rosuvastatin have the highest bioavailability and the longest half-life of any of the statins on the market. And you do want to exert some caution with high-intensity statin therapy, particularly in people over the age of 75, impaired renal function, frailty, multiple comorbidities, and with a fibrate because of the rhabdo risk that goes with it, which is still incredibly rare. Moderate intensity statin therapy reduces the LDL by 30 to 49%. And you can see that's lower dose of atorvastatin and rosuvastatin, but that's where simvastatin, pravastatin, and lovastatin come in. Simvastatin is the statin that, even though rhabdo is super rare, it is the statin most often mentioned in statin-induced myositis. It is for a variety of reasons. And then low intensity statin therapy, I'm not even going to mention that because it's not indicated. And this is a quick and dirty way of remembering how much you get out of high intensity statin therapy and moderate intensity statin therapy. LDL will go down by 1/2 or more with high intensity statin therapy. Moderate intensity statin therapy, the LDL will go down by 1/3 or more. All right, so just kind of a quick way of remembering that. And this just gives you an idea of statin versus statin, how much you can squeeze out of a given dose. Now, remember what I said just a couple of minutes ago about like doubling the dose of fill in the blank for high blood pressure? Does it mean doubling the blood pressure lowering effect? Look at this, and I'm just going to point out rosuvastatin Crestor towards the bottom of this table. You'll notice when you go from 10 milligrams of rosuvastatin to 20 milligrams of rosuvastatin. At 10 milligrams, you got 50% LDL lowering. At 20 milligrams, you get 53%. Interesting, huh? And then if you do go up to 40 milligrams of rosuvastatin, which there's some caution on going that high. It's actually, it's used sometimes, but that brings you up to 62%. So in other words, doubling the dose of the statin does not double the LDL lowering. It doesn't. So you get that very much that law of diminishing return. And like a lot of people will have muscle aches, not myositis, on like 80 milligrams of Lipitor, but not on 40 milligrams of Lipitor. Look at the LDL lowering difference between 40 and 80. 40 milligrams, 51%, 80 milligrams, 54%, right? So what, true or false? One study conducted by the FDA examining adverse effects reported suggested that over 50% of the cases of statin-induced rhabdo were due to drug interactions. And that's true. That's true. So they seldom occur spontaneously. They usually have something else going on underneath it. And here's something that often comes up. Okay, you can't drink grapefruit juice while you're on a statin. Well, maybe you can, okay? Because what grapefruit juice does is it inhibits cytochrome P453A4 at the intestinal level, at the intestinal level. And the only statins that are 3A4 substrates are atorvastatin, lovastatin, and simvastatin. And this is one reason. There are a number of reasons why rosuvastatin is my favorite statin, but that's a 2C9 substrate. But that's one of a number of reasons why I prefer people taking rosuvastatin. A lot of clinicians think it's very expensive. It was really expensive till, maybe like somewhere between 5 to 10 years ago when it went generic. And then the price really tumbled. It's probably a few dollars a month more than atorvastatin, but it's very well tolerated with a lower risk of drug interaction. You know how you'll hear people say, oh, you can't take Paxlovid if you're on a statin? That's because the ritonavir that's in Paxlovid is a potent 3A4 inhibitor. You can take it if you're on rosuvastatin. Right there. You've got one there. So other than typical indications, where would rosuvastatin and baby pravastatin fit in? The person in need of statin therapy who's also on diltiazem, 3A4 inhibitor, and that a person who is a heavy chronic grapefruit juice drinker because it's a 3A4 inhibitor. It's interesting on cruises these days. If you've ever been fortunate to go on a cruise, or maybe that just sounds like not a good thing you'd want to do, but cruises can be a lot of fun. You can eat, you can drink till your heart's content. You cannot find a darn glass of grapefruit juice on most cruises. And the reason is they've had too many passengers have grapefruit juice drug interactions. So most cruise lines don't carry grapefruit juice anymore. It's interesting. You could eat yourself into a mild coma, but you're not going to squeeze a glass of grapefruit juice out of them. All right. So what do you do with repeating lipid profiles for people on dyslipidemia therapy? And this would be an example, by the way, of an evaluation question on the NP boards looking at response to therapy. You do it after 4 to 12 weeks of statin initiation or dose adjustment, then repeat every 3 to 12 months as needed. General rule, you get them down to LDL goal, like within 6 months of starting therapy, and then they can just go on annual, for the most part, annual checks of their dyslipidemia. This, by the way, and I might have mentioned this table in the pharmacokinetics, pharmacodynamics class that I did, which was the first one in this series. This is a table. It's open access. It is worth its weight in gold. It's from Indiana University School of Medicine. So a great resource. And it is the Flockhart table. It is a streamlined table of drug interactions because, one more time, our dear drug apps overwarn us. This is the real deal. It will tell you when you really do need to worry about something. So how can I approach a patient who has high blood pressure and dyslipidemia who states someone is trying to get rich off of these medicines you're telling me to take? Okay, this is the reality of the world we live in these days, or at least in the United States these days. If I hear one more time that clinicians make bundle off of immunizations, I might lose my mind. But let's get back to the topic here. So one way is by showing the patient the impact of treatment. So this is a 45-year-old guy who smokes, has high blood pressure, type 2 diabetes, okay? And at 45, without therapies for his lipids, his high blood pressure, no aspirin, his 10-year ASCVD risk today at age 45 is 20%. And what would it be for a 45-year-old man who doesn't smoke, doesn't have high blood pressure, doesn't have type 2 diabetes? It would be 2.1%. All right. His total cholesterol is 220. He has a goal LDL of less than 70. If he only goes on something to help his cholesterol, his LDL get below 70, his 10-year risk goes from 20% to 15.4% by just adding a statin. His current BP, if his current BP was at 130/80 without hypertension therapy, I probably should have made that blood pressure a little bit higher, but now treat his high blood pressure and his 10-year risk goes to 11.3% with high blood pressure in high-dose statin therapy. FYI, I haven't mentioned a single expensive drug tonight. They're all generic. They're all cheap. If you add low-dose aspirin therapy, it takes that 10-year risk to 10.2%. So we've done high blood pressure, high-dose statin, high-intensity statin therapy, and ASA. He started at 20. He's down to 10%. If he quits smoking, it goes down to 7.2%. All right. So I can play fast and lose with math. That's almost a 2/3 reduction with very standard, very inexpensive therapies. Pretty impressive, isn't it? All right. So this is one way this could look at if is presenting LDL for, or I should say, I'm switching gears here. For severe hypercholesterolemia, this guy's presenting LDL is at 240. He smokes, he has high blood pressure and type 2 diabetes. His goal LDL is less than 70. So high dose atorvastatin, high intensity at 80 milligrams a day, his LDL comes down to 130. That's really kind of a miracle, but it comes down to 130. Because remember, it is 50% or more. Add Zetia, and that is one of the best tolerated medications in the world because it is not absorbed systemically. But it will only bring his LDL down to about 110. But remember, we started at 240. And then this is where the expensive meds come into play. Drugs like inclisiran and Repatha. And they are injectable only meds that probably run $4,000, $5,000 for a year. But that can take his LDL then down to 50 milligrams per DL. He started at 240. That's a miracle. That is a pharmacologic miracle. Now, the last one, the Repatha or the inclisiran, they are expensive. The rest are all cheap and generic. So questions or comments? I can see one question came in, and I want to thank you so much. This has been an unbelievable turnout for this program. So roller beta blockers as first line, add-on as second line. Which beta blocker do I recommend? All right, by the guidelines, because, we're teaching people, so we really have to stick to the guidelines. And I always say to people, we practice a big chunk of art and a big chunk of science. We do both of these. Where the beta blockers fit in, according to ACC and AHA, is a med class to go to when and if you can't achieve blood pressure control with the big three, the ACE inhibitor / ARB, calcium channel blocker, or thiazide diuretics. Okay. What's the most commonly prescribed beta blocker? It's metoprolol. You want to do the extended release form that's once a day. And so one of them is tartrate, the other is something else. Anyway, just look up whatever the extended release metoprolol is. And that will lower the blood pressure then more by working on heart rate and stroke volume. Particularly good choice when you've got a person who's at very high risk for a cardiovascular event. Because of what do we know now? People with ACS, unless it's a contraindication, they usually go on a beta blocker post-event because of its effect in part on cardiac rhythm. Now, I will give you another hint of something that I sometimes prescribe, particularly when I've done 3 meds and I ain't nowhere near good blood pressure control. Yes, and I've ruled out secondary hypertension, and if there's sleep apnea, I've treated that, but I'm just like at my wit's end, and maybe I've even run them by cardiology, whatever it is. What I will sometimes add is a med we usually don't think about as a high blood pressure medicine, but definitely a heart failure medicine, and that's carvedilol. Coreg. It's an alpha beta blocker. It does come in a once a day sustained release form, but in the generic form, it's BID. So I can't get the insurance companies to pay for the once a day form because it's expensive. The BID is cheap, okay? And why would I say carvedilol and perhaps not just go with the flow with the metoprolol? Part of the reason is that alpha blockade, where are the alpha receptor sites? They're in the peripheral vascular bed. So you get the beta blockade in the heart, but you get the alpha blockade in the vessels. And the alpha blockade also mildly enhances insulin sensitivity. So it's not going to take somebody and make them hypoglycemic if they've got type 2 diabetes, but it's not going to worsen their insulin resistance, which beta blocker therapy can do. And it's generally very, very well tolerated. But I only consider going with the carvedilol if I have somebody who generally is highly adherent to whatever therapy I have prescribed for them already. Okay. And by the way, you'll always will read that beta blocker therapy has to be tapered. We all know that, right? But the rationale behind that is that those the rationale behind that is those beta receptor sites have been all blocked off from being hit with catecholamines, and you don't want to just open them all up to the catecholamines at once. So a couple of week taper is generally all you have to do. All right, any other questions or comments? Well, if there are none, I want to thank Riley for helping us out tonight. I look forward to seeing you at future programs. I'm doing this off the top of my head, so please bear with me. I think the next one I'm doing is on antibiotics. I think that's what it is. Anyway, so thank you so much for joining me tonight, and thank you for all you do for educating the next generation of nurse practitioners. Take care.